In this panel, we want to address the appropriateness of international surgical training for high-income country residents and fellows, and discuss the logistical and ethical aspects of such engagement. The issues discussed in this panel are becoming increasingly important, primarily because of increasing resident demand. In 2009, Powell and others conducted a survey of American College of Surgeons resident members. They found that 92% of residents were interested in international training opportunities. Significant barriers to accessing such overseas training opportunities are common, including both a lack of funding and obtaining time away from clinical roles. Despite high educational indebtedness, a significant proportion of residents were willing to fund their own overseas experiences. And despite long clinical work hours during training, a similar proportion were willing to use vacation time for international training. Yet the skills needed to contribute well to global surgery are typically absent from clinical training programs. In 2012, Dr. Paul Farmer and Dr. John Mira stated that the academic global surgeon must be trained for both the operating room and the boardroom, wielding scalpel and spreadsheet with equal facility. Formal clinical programs rarely include sufficient training in fiscal management, program evaluation, or even the clinical breadth required to contribute to clinical care at the district hospital in a lower middle income country. However, engagement is not always beneficial to both parties. In a recent survey of surgical and anesthesia trainees in Uganda, it was found that 75% agreed that visiting groups improved training. However, only 15% agreed that research projects of visiting groups were in the greatest priority areas for Uganda. 28% of trainees had participated in such research collaborations. However, none had published as a co-author. When high-income country trainees engage in global surgery, there is potential for bilateral benefit, but also for significant bilateral harms. How can we promote the former and mitigate the latter? Putting the issue within the framework of the Commission, how can senior trainees in high-income countries work to close the research gap, improve information management, bolster the surgical and anesthesia workforce, and ultimately improve the delivery of surgical care? We are fortunate to have an incredible panel of speakers addressing this topic. Dr. Haile Debas will be moderating. He is the Maurice Galante Distinguished Professor of Surgery Emeritus at UCSF. He is a lead editor of the Essential Surgery volume of the DCP3. He is considered by many to be a founding father of the modern field of global surgery. Dr. Adil Haider is the Kessler Director of the Center for Surgery and Public Health at the Brigham and Women's Hospital. His personal and professional goal is to eradicate disparities in healthcare. He is a recipient of the American College of Surgeons Jacobson Award. Dr. Craig McClain is an anesthesiologist at the Boston Children's Hospital. He is a co-founder of the program in global surgery and social change at Boston Children's and Harvard Medical School, and he is a founding director of the Global Pediatric Anesthesiology Fellowship at Boston Children's. He serves as a lead anesthesiologist at the Harvard Medical School for Rwanda's Human Resources for Health program. Dr. John Tarpley is a general surgeon who spent much of his early career in Ogbomoso, Nigeria. He knows residents very well, having served as a general surgery program director in the US from 1995 to 2014. He is on faculty at the Vanderbilt Institute for Global Health. Dr. Ainhoa Costas is an honorary assistant professor at the University of Rwanda. She is trained in both general and hand surgery and presently serves as a consultant surgeon with Rwanda's Human Resources for Health program. And finally, Dr. Louis-Franck Télémaque is with us from Haiti, where he is a professor of surgery at the Hospital of the State University of Haiti. He is trained in Belgium, France, Haiti, and the USA. He has been training surgical residents in Haiti for decades, is intimately familiar with their training needs, and has seen firsthand both the benefits and harms of visiting surgeons. Dr. Debas.
Good morning. It is a wonderful beginning. And I was telling John that he's been so successful in his articulation of the importance of global surgery that the former Harvard Dean of Medicine, Dr. Joseph Martin, for whom this center is named, was here to listen, and he was extremely impressed. So Josh, thank you very much for articulating the contents of our discussion. You know, it's a great privilege to be part of this launch, because this is, as so many have said, is the beginning of something very important in the history of surgery in general and global surgery in particular. I have said that the Commission report is a landmark piece of work, and I could wax poetic in describing it. On the other hand, they haven't given us much time for this discussion, so I will curb my enthusiasm for a moment. So our allotted time is short, and I'll ask the panelists one question each before we open it to the floor. I hope we'll beat the yellow light at that time. I would ask that all the questions be short, including mine, and all the answers be short. So with that, I'll start with my first question, which will go to Dr. Haider. Dr. Haider, what do you think are the key conditions necessary for residents to have a positive impact and sustained engagement in the academic field of global surgery? And just, I'll add to that end, do you think departments of surgery should have formal programs or centers in global surgery?
Thank you very much for that question, Dr. Debas. Before I say anything, I wanted to do two things. First, I wanted to congratulate the commissioners on the wonderful report and share with you the tweet that I did, because I know we're all tweeting, right? That's what we should be doing. So the tweet I gave out was the GS Commission at the Lancet provides great direction for all surgical academics to pursue. And I think that's one of the greatest things we're going to get out of this report is direction. You asked about how can we continue to help residents who are pursuing careers and make them impactful. So first I'd like to ask, how many residents or surgical trainees in this room are currently engaged in global surgery? So I know some, please just stand up for us. Go ahead, stand up. Go ahead, yeah. So I think first thing we could do is to recognize them all, so congratulations. And I think there, Dr. Bust, maybe three things. First, we need to create the circumstances and the correct environment for residents to go. So I was working with this one resident. She had not been overseas many times. She was a PGY4 at my previous institution in Baltimore, and she went to Kenya, and she had a horrible time because the first thing that happened when she got there was that there was a patient with a difficult problem, could have easily been saved in the United States, was not provided that level of care, or that level of care was not there, so she couldn't get that level of care. The patient passed away, and this woman broke down because she just didn't know what to expect and could not deal with it. So explaining from beforehand how it's going to be and what needs to happen is, I think, an important ingredient as we prepare our residents to go. The second thing, and this dovetails with why I agree with you that there should be centers of excellence in global surgery, regards to research. So you mentioned in the presentation that many surgical residents and trainees from here like to go overseas and pursue in some sort of research. And I think that works great because it keeps them involved and then engaged for the long term. But it needs to be a two-way street. You know, if you think of so many others who do global surgery research, one of the great things is to have, linkages and know colleagues from that part of the world who are doing research. And one way to do it is to not just have our residents go over there to do research, but also have residents from other places that we're partnering with come over here. An example of a program is where we had research fellows who are in their own country working, but come to the States for 2 or 3 months at one of these more advanced centers, see and experience and develop strong partnerships with people as they're doing research, and then go back home. And that kind of like intercontinental communication, I think, is necessary to allow residents to have those kind of linkages and supportive relationships that could then lead to good academic productivity. And then finally, yes, I do agree that trying to bring all these things together in a center format or context really is helpful.
Thank you. My second question is to Dr. Tarpley. Based on your experience working in Nigeria, and more recently with your SEGME, ABS approved electives for Vanderbilt residents in Kenya, what allowed visiting surgical residents to develop mutually beneficial long-term partnerships with Nigerian colleagues? And what were the biggest mistakes that surgical residents made? I never thought the surgical residents made any mistakes, but take it.
Thank you very much, sir. I, too, am very proud to be here, and I'm honored to be the person who's asked about mistakes. We're told if you want to improve, you need to double your mistakes, but that's another issue. I think the key thing for having successful relationships, and these relationships are initiated, are in progress, and I think seeing them as long-term relationships instead of short-term jaunts or junkets is really important. I think, as has been alluded to already by Haider, is that preparation before people go is key. I think you need to have a briefing session before people go and talk about realistic expectations. You're not going to solve the problems of the world in a 4-week visit. I mean, you're not even going to know the vocabulary or what those problems are, quite frankly. So I think that to have the preparation, the briefing, to have realistic expectations, and then to have debriefing when you come back. So like we're having 4 people in our home tomorrow, Sunday night, who are our next group of residents that are going to Kajabi Hospital in Kenya. And we will have people who have been there previously on the same rotation so that they can be given some idea of what to expect. We have a manual that they must go through ahead of time, and they don't always agree and follow the guidelines. So the mistakes that we've had were 2. One is in the planning. We thought an R4 would be preferable to an R3 because they could actually do something. And our R3 year is a very heavily operative year, and I thought that would be a better year for them. The mistake is that many of them are coming out of the lab, either the residents themselves, and we've had 2 of our residents at the R4 level deliver this year. They had a new baby, or they were in labor, or their spouse. So we had child issues that affected us at the R4 year, but also in the latter half of the R4 year, people were interviewed in pediatric surgery, and that takes about $40,000 in 4 months to do. They were interviewing in plastics, they were interviewing in vascular, and now they're fixing to interview in surgical oncology. So it's really, the second half of the year is almost verboten. So we're ramping it back, and we're going to do latter half of R3 and first half of R4 as we move forward. So that's a logistic planning issue that came up with us. We have strict rules about avoiding risk-taking behavior. And a key thing there is driving at night, riding on a motorcycle, and doing crazy things. And so we had one of our residents who decided he was going to run a marathon, but guess what? He had had diarrhea the week before, and he was not in good shape, and that was a mistake, and we ended up having to evacuate the guy. So common sense, you can ask him to use common sense, but it doesn't always happen in my experience. So those are the two mistakes that we have made, and then I have some closing comments at the end, and I will save the rest of my time for that.
Thank you. Thank you. The next question is to Dr. Costas. Welcome, Dr. Costas. Do residents from high-income countries have a role in the operating rooms of low-income countries? If so, under what circumstances? In your experience, what factors have contributed to positive HIC-LIC resident interaction?
Thank you, Dr. Debas. I think this is a very important question, and I'm honored to be asked it. I think a lot of the interest now in surgical residents going to low-income countries often comes from the point of we're not getting enough open procedures where we're practicing. And I think we need to be very wary of that and move away from what I consider the concept of surgical colonialism, where if you consider patients and open procedures to be the valuable commodity, and then we come in, we mine these resources, and then we leave. And that's not the purpose of sending residents to practice there. I think the main goal for sending residents to these countries is what's been voiced before, is the concept of accompaniment. And so how residents can participate in the operating room, I think is threefold. It's through observation, education, and advocacy. They can learn, as Dr. Riviello mentioned earlier, to walk the walk, to go down to the river, to see what it's like to practice in these countries, to be in that operating room and understand what it means when you're in the middle of about to ligate or clamp some vessel, and then the light goes out, and what do you do? So these are very valuable experiences for our residents. The other part of the educational component is that as a resident in the United States, you learn and practice how to train that intern, the second-year resident, the third year, everybody that's below you, and that concept is not necessarily there in the low and middle-income countries yet. So it would be wonderful for them to model that educational practice so they can take time aside and teach the medical students how to tie, how to do a suture ligation, all of these small things that we take for granted that are not in place yet. So that's where I think that residents are most valuable. And then the other part of advocacy is seeing all these things that we need to promote change in. For example, if we don't have electricity, we don't have running water, we don't have the medications that we need, we don't have the sutures that we need, the residents can see these things happening, and then they can take part of big things such as the Lancet Commission in Global Health and push for these changes to happen.
Thank you. Thank you. Next, my question is to Dr. Télémaque. He'll bring a rich French accent to this panel discussion.
Sorry.
Is there a role for high-income country residents in clinical and research work in hospitals like yours? What would you want from visiting high-income country residents in order to ensure reciprocal benefits?
Thank you for this extraordinary opportunity to be there and to participate in the summit on global surgery. You understand? My English is very poor. My country, Haiti, is traditionally open for bilateral exchanges and global surgical cooperation. My answer to the first question is, and start, on our perception of HRCR profile. We in Haiti, we consider your residents to have different medical culture based on evidence, have strong paraclinical precedence, develop rigor, discipline, and process on base protocols. They develop a comprehensive approach to complete their training, and they have access to large database. They train for research too. So when they come in Haiti, they are welcome. They could assist us in decision making. They can help us to develop database. They can train and coach our residents to scientific and technical researches and help us to the local development of new technology. How our hospital like us want from visit for visiting high-income country residents in order to ensure reciprocal benefit. Our hospital, generally, our university hospital are reference hospital, and care patient with very low income and often in time of crisis. Diseases are different from those here, and we optimize services with very limited resources like human, material, and financial resources. We do not have research and development practice. And now many hospitals are in development or in construction. So we could develop reciprocal benefit. Residents from high-income countries discover a different epidemiological reality. Could develop clinical skills without paraclinical possibilities. Can develop more practice because they have more latitude in decision-making and surgical procedures. Could benefit from the opportunity to apply expertise locally. Benefit from the large hospitality and mind openness of local resources to international cooperation. Our hospital benefit from the possibility of exchange like literary, cultural, academic, and linguistic. Is there, I try to learn English. Establish international contact, like internship and facilitating for more open international cooperation. We develop advocacy for the development of more international support and more open, constructive training in foreign university hospital. It's very important for us. Training and development of new technology locally, support our young scientific effort to research and publication, and help us to have access for databases.
Thank you. Anesthesia is an equal partner to surgery in global surgery. And the reason Dr. McClain is at the end is because dessert comes at the end. Dr. McClain, can you talk about the process you went through to develop fellowships in global anesthesia?
Thank you, Dr. Debas. I first want to congratulate the Commission on the production of this landmark document and say I'm very flattered and honored to be here, and thank you for the invitation to speak. Dr. Paul Farmer has famously stated that surgery is the neglected stepchild of global health, and I would submit to you that anesthesia is the invisible friend of that neglected stepchild. So we have at Boston Children's Hospital have created the Global Pediatric Anesthesiology Fellowship, and what that is it's basically a postgraduate fellowship designed to help develop academic leaders in global anesthesia. This came about from talking to some of my colleagues who at our institution and others who had gone through much the same process of getting involved with this kind of work, and you realize that everybody's telling the same story over and over again about struggling with trying to convince leadership that this is a worthwhile endeavor and these sorts of things. And that coupled with the fact, as Josh spoke about earlier, that there's clearly an increase in interest across specialties in this kind of work, led us to try to think about, okay, well, how can we make this easier for people? How can we create a pathway for them? So there was clearly an opportunity, and we looked to some of the other specialties that had done this sort of thing, particularly in our hospital, pediatrics, and then the small army of global surgery fellows that John Mira has created. And we thought we could do this for anesthesia too, and this would be a nice vehicle to get people involved. The main components when we were designing this, we wanted to make sure that people had time. Time is always the currency in academics, and doing this kind of work doesn't lend itself to like a single non-clinical day a week. You need blocks of time. And so when we were thinking about the proposal for this, we created a work service model. So it's a year-long fellowship. And the idea is that the fellow will work for 6 months as faculty, make half a salary, and then the other 6 months is fellowship time where they can engage in a project. I purposely sort of started without having to ask my chairman for much because I wanted him to say yes, and which we've done now, and We've had a couple of fellows come through. We have one more coming this coming year, and unfortunately, my chairman has been incredibly supportive. I think he sees the value in this work, and because of this momentum, we've been able to get the hospital to fund us a little bit, and we've been able to expand what we can offer now, and not just an opportunity to engage in an academic project in global surgery and anesthesia, but opportunity to pursue advanced degrees that can help, once again, develop this, the future leadership of this. So,
thank you. We'll now open the question to the floor, and I'll take a few questions, and then I'll have the panel respond, and then we'll go further. So, questions, please, and please identify yourselves and where you're from. Yes. Oh. Don't be shy.
Hi, I'm Eric Nagengas from the University of Nebraska. One of the ways that residents and fellows engage in global surgery is through research. I was wondering what your perspective is on how we can best choose which research projects to tackle and how we can get local people involved.
Okay, we'll take another question.
Yes, Susan Briggs, Mass General Hospital. As someone for 40 years as a trauma and general surgery who's not only taught our surgical residents, but also worked in Uganda, Haiti, and Rwanda, our courses through the college have a lot of things that could be adapted, but the college has been very inflexible about treating low and middle income countries the same as high income. Should we develop our own global surgery course for people like John described going, or should we push to try to incorporate it in some of our general surgery training? They don't know how to do laparotomies very well anymore with minimally invasive surgery. They do not know how to do C-sections. What is the way that the panel would recommend?
Well, next question.
Hi, Lori Ramonzi from Engender Health Fistula Care Plus, also serving as doppelganger for Kate Grant from Fistula Foundation, apparently. I'm wondering what the panel thinks about the possibility of creating not only research reciprocity, but also clinical reciprocity, where colleagues that we're working with overseas can come and do hands-on care, arguably as the best way to immerse oneself in the systems that we have that are evidence-based and quality assurance-based. And also specifically for the anesthesia fellowship program that you're developing. Have you partnered at all with local programs, for instance, the Kijabi Hospital Regional Anesthetist Training Program that's working throughout the Horn of Africa to enhance the global aspect of your program? Thank you.
Thank you. Thank you particularly for that last question, because there is no reciprocity when the residents come here and they can't do clinical work. And we expect ours to go there and engage in clinical operative work. So let me throw it to the panel. You can take these questions in any order you want.
Let me respond to the last question. I think when medical students and residents go abroad, it's almost like you're planting a seed, and you don't know what's going to happen 10 or 15 years later. So, for example, Mark Newton spent 4 weeks in Nigeria as a medical student. What is he doing right now? He's running an anesthesia CRNA training program at Kajabi Hospital in Kenya, and he's just gotten a grant from Westinghouse to put that out into Western Kenya as well. And he's gone through the Kenya Medical Council. He's done everything legal. Everybody's being licensed. It's being done appropriately and in order. And he's bringing in people not only from Kenya, but all over East Africa. So I think that one of the things we need to see about medical students and residents, and I will assure you they are time bandits for the receiving folks on the institutions there, quite frankly. It's a pain to get them through, the travel, make sure their housing's okay. There's just a lot of cost. But if you look at the people who are in Kajabi right now, who are expatriates, who are basically planted their lives there, and so there are long-term and then there are short-term possibilities. But a lot of the people that are currently training and delivering care in many parts of the world are people who went and got a vision when they were a medical student or a resident. So I think it's an equity investment, and that's what Mark's doing, and he's trying to export this model to other countries close by.
I'll comment on the question regarding what kind of research to pursue if you go overseas. And I think the key to that, if you want to be successful, is to partner with colleagues from overseas, whoever your host institution is, and understand from before you get there, what are their needs. After you ask that question, I just PubMeded a colleague. His name is A. Shah, to see what kind of research this person has done in a very similar context. And the guy published a great paper looking at a hospital and had some experience from here on quality assurance, and went and this hospital had some sort of electronic medical record, a rudimentary kind of electronic medical record, but used that to understand where the problems were in quality, and basically found that after trauma, the number one reason people were dying was in the perioperative stage. And when you dug down deeper, it truly was availability of blood around the surgery. And so he was able to provide a very useful research project and got it published. And of course, his co-authors are from the host institution. So having developing a partnership before you even get there and focusing on something that's important to your host institution is probably the best thing to do if you want to go and pursue a research project overseas.
Craig?
I'd like to add a few comments to that as well. I completely agree with Dr. Haider. I also believe the importance of residents in helping with research is that when you take that year or 2 years off, you have the luxury of time and resources that the faculty or the students on the ground do not. Therefore, you are able to do a lot of the legwork that they would like to do, but they otherwise are unable to, or they don't know how to do. For example, I have a good friend right now. He's a medical student in Rwanda, and he has spent several weekends now teaching a Rwandese student how to use Stata. And therefore, she was able to do her own research project and came back to him and showed him her analysis and said, look at what I did. And that's another way that residents can help in research.
Craig?
I can address a couple of these questions. So I was asked about whether we'd partnered, and we've partnered with HRH. So we sent a couple of fellows to through HRH, and the research question is interesting to me because as I've talked in a number of countries with consultant anesthetists there, there is little to no incentive for them to do research. And so so then the question I have to ask myself is, well, yeah, I want to know this, but as I know, I put it just basically being a sort of medical research colonial person, and so I think that part of what we need to do is, if we want research to be done, if we think these questions are important to answer, then we need to make sure that it's incentivized in the country that we're working in as well. So.
Yes.
Getting back to the other question about can it be reciprocal on the clinical end, I mean, it's very difficult for somebody from Massachusetts probably to go to New Hampshire. I mean, we've got licensures and all these other kind of stuff, and then you throw in the ECFMG and everything, all the hurdles you have, it's very difficult. They can have a meaningful clinical experience in many ways without ever scrubbing, I think, but it's very, very difficult medical legally getting them registered and making it available for them to do clinical practices here. We have been able, I think enlightened leadership, this was actually referred to earlier on the anesthesia front, but if you've got department chairs who see that this is good for that department, that it's good for the personnel within the department, and you have enlightened, sympathetic leadership, it's really a big deal because our chief of anesthesia at Vanderbilt has had our CRNA instructors from Kajabi brought to the United States, and they would spend 5 weeks, 6 weeks here with our people, going to all the conferences, seeing all the bells and whistles that we have, which they don't have, but the principles are very, very important moving forward. So it's difficult, it's hard to do, it's expensive, you can't do everything, but you get a lot of bang for your buck if you pull it off.
Okay, I think, am I right, the time is over? Yeah, so we have a bigger panel than the others. That's our excuse. But I want to thank the panelists for their wonderful contributions. Thank you very much.